I'd like to go ahead and introduce our guest presenter today, Dr. Jen Kaiser, who will be presenting her talk entitled IUD Insertions and Removals, What to Do When It Just Won't Go. Dr. Kaiser is an assistant professor of obstetrics and gynecology and a complex family planning specialist here at the University of Utah. Her clinical interests include contraceptive care for patients with complex medical issues, prenatal care, gynecologic care and surgery, miscarriage management, and in-office procedures. Her research interests are varied and include contraception counseling, mifepristone use for miscarriage management, adolescent contraceptive care, and improving reproductive life planning for individuals with substance use disorder. In addition, she's an excellent clinical educator and is responsible for designing and implementing the simulation curriculum for our resident physicians. Dr. Kaiser runs a procedure clinic at the university specializing in complex IUD and implant insertions and removals, and has graciously volunteered to share some tips and wisdom about tricky IUDs today. So without further ado, I will turn it over to you, Dr. Kaiser.
Thank you, Dr. Clement, for that wonderful introduction. Welcome, everybody. I'm so glad that you could all make it today. And I hope that some of this is going to be a little bit interactive. So feel free to jump in, unmute yourself, put some stuff in the chat. I'll be watching that as well. And we will talk about difficult IUDs. All right, so today we're going to cover both insertions and removals. For the difficult insertion side of things, I'm really going to focus on mainly cervical issues and some tips there as far as checking the curve of the uterus and also cervical stenosis, and then some tips on pain management as well. And for removals, we'll cover what to do when there's no strings, what happens if the ultrasound says that it's embedded, and then what should you do if there is an IUD still in place and the person is pregnant. My big take-home tips that I want you to take away from this, number one, always use a tenaculum when you're placing an IUD. If you can use a curved sound is very helpful. Also, when you're trying to do a stringless IUD removal, know that the device is going to be just past the internal os almost all of the time, and I'll talk more about that when we get to that part. And then if you're there doing a removal and there are strings, just pull the strings. So our first case, so Lauren is a 28-year-old G0 here for a Paragard placement. She has a negative pregnancy test, has a history of a leap 3 years ago. Last pap smear was normal. On your exam, the uterus is retroverted but normal sized. You are placing the speculum, and note that the patient is pretty uncomfortable with that already. And when you actually see the cervix, you notice that there is just kind of a little pinpoint external cervical os. So here's our first chance of participation. So what makes you concerned about placing this IUD in this patient? And chat or unmute, either one. Discomfort, with just speculum placement. Yep, worried about how she may tolerate the actual insertion, good. Yep, hasn't been pregnant before, the leap, concern there, like cervical stenosis. Okay, great, we can go to the next slide. Thank you for jumping in on the chat. So yeah, so things here that, stand out to me, the leap, right? So, what is that cervical canal doing? Is it scarred? The retroverted uterus can make these a little more tricky. The low pain tolerance with the speculum placement, and then of course you're visualizing a pretty pinpoint cervical os. So how are we going to approach this placement? Next slide, please. So you really want to set yourself up for success. So make sure that you are always doing a bimanual exam to assess uterine position and size both. This is really, really important. It took me it's embarrassing to say how many years probably to actually remember to do an exam every single time. There's so many times where I'd place a speculum and then be like, I forgot the exam and have to take it back out when I was training. But always do your bimanual. And then the tenaculum is also very, very important. you should really never be doing an IUD placement without a tenaculum. And that is primarily for this issue of helping yourself align the uterus and the cervical canal. And you can see in this little animation here, how that traction on the tenaculum is helping to straighten the uterus straighten the cervix and uterus. And it's going to help your placement be a lot easier. So you want to keep a firm grasp on your tenaculum, and you can apply gentle traction to align the uterus. And most people, when you're kind of pulling on the tenaculum to align things, that part isn't that uncomfortable for them. And so don't be afraid to go ahead and really kind of pull on it, you know, a nice, firm, gentle traction towards you. You want to hold your sound really lightly to navigate the canal. So if you're doing your steady, gentle forward pressure with your sound, if you have a really firm grip on it, you might miss the fact that the cervix takes a little loop-de-loop before you get into the uterus. And so holding it lightly is going to let the sound spin a little in your fingers and help you navigate and find the pathway of the canal. And so what happens then if you get resistance at your internal os? So we'll get to that in 1 second. So maybe you've done all this for this patient we're just talking about. You've gotten good, like decent traction on your tenaculum, and you're like, I'm pretty sure I've straightened out her uterus, but I still just cannot get this sound to pass. So there could be sort of a branch point here, and sometimes these go together. So are you encountering some cervical os resistance at the internal os, or is this mainly due to patient discomfort, and every time you're trying to advance the sound a little, the patient is just very uncomfortable? So if it's more an issue with the cervical os, you have a couple of different options here. So say you've tried with your sound, you just can't find the pathway, you keep hitting a dead end. You can use something called os finders or cervical dilators, and I have a picture on the next slide. So the picture here on the left, those are the os finders. You can see that they come to a pretty narrow tip and they're tapered. And so those, you know, if somebody does have more of a pinpoint os, somebody who's had a LEEP or other issues with cervical stenosis, this can be helpful for sort of finding that internal os. And because they are tapered up a little, you can go ahead and advance those a little more to start to dilate that internal os. Of course, you can also use just regular cervical dilators, and there's some pictured there in the lower picture. What I really like is this thing called the sound dilator. It's a plastic device, comes sterilely prepackaged, and one side is a wider diameter than the other. I always start with the smaller side just because it's a little more comfortable for the patient than just starting with the thicker side. And oftentimes you can find your way through a cervix just using this device alone, and they're I believe they're pretty cheap. And if you are interested in them for your clinic, Caitlin, who's on the call, and Erica can both help you get those. But that's the one that I really like. So Mesoprostol, I have lots of patients who are sent to me who either have had a difficult insertion in the past or, you know, maybe have a failed insertion in clinic with their provider. And the patient sometimes will be like, the last time I had my IUD placed, they told me to take this medication beforehand called Mesoprostol. And so the evidence for this is that you should not use this routinely. You should not just give this to people like kind of quote unquote prophylactically before attempting their like a first IUD placement. There's a systematic review that showed no improvement in either ease or successive insertion. And actually it causes increased insertional pain because it's stirring up prostaglandins in the uterus. And it comes with some pretty, you know, not fun side effects: nausea, cramping, diarrhea, vomiting. And really the only time when there has been some benefit shown is in people who have a failed prior insertion where you really think it was due to cervical stenosis. So in my clinic where I get a lot of referrals for difficult IUD placement, I have maybe used Mesoprostol like once. And so I just is not something in my toolbox that I find that I need that often. And even if you have somebody coming in, you know, who's never been pregnant or whatever, like I would not recommend that you use this routinely at all for those patients. So what if it's more patient discomfort, or maybe you have both? Maybe you have a stenotic cervix and the patient is just very uncomfortable, like our case today. So it's important when you are doing your consent and everything that you really set expectations. You want to discuss the insertion steps, and it's important to be realistic, right? That cramping is normal and expected, and provide reassurance about that, and that, you know, the procedure is quick, that you're here and you're going to talk them through it, and that, you know, if they need a break or a pause, that's okay, and they can ask for that. So other pain management strategies. So NSAIDs reduce post-insertion pain, but not insertional pain. There's no evidence for the use of topical lidocaine, and even paracervical block, so using like a 1% lidocaine injected in the cervix, and I'll show you a picture of that in a second. The evidence there is conflicting as well, as far as like how much does this actually help people. And so in our practice at the U, really we just work on setting those expectations that, you know, there's going to be some cramping and discomfort, and we try to get them some ibuprofen at least 30 minutes prior to placement, again, to help with the post-insertion pain. So the paracervical block, so when to use this? So I tend to use this if I am going to need to dilate. And so sometimes if I have a patient who's been referred for difficult insertion, I'll have my clinical team just have some available for me in the room in case I do need to dilate, and then I have it and I can give it quick before dilating. And then also, like in somebody who maybe is like this patient case we were just talking about, where there's some real concern that, you know, there's been a lot of discomfort so far with the early steps, and whether or not, you know, this is going to be something that's beneficial just to do before you even try to pass a sound. But I would not, again, recommend this for routine use either. So this is how I like to do the paracervical blocks, and this is how many of the studies have done it as well. So just using 10 cc's of 1% lidocaine plain. You know, you would do your tenaculum site if you haven't placed your tenaculum already. Then at the cervical vaginal junction, so in this picture you can see here at 4 and 8 o'clock, you're going to inject, you know, about, I do more like an inch rather than a centimeter. Make sure you aspirate always, and then you're going to give 5 cc's at each of those sites. All right, so tips for success for the difficult insertion. Again, important to always perform a bimanual exam, place a tenaculum and use it. It is your friend. Have some dilators or os finders available in your clinical setting for the placement of if you're anticipating that you may have difficult IUD placements. And honestly, like, you don't really know when people come in. And so if you are doing IUD placements, you will come across one of these. So having these tools on hand is really helpful. You can always use your paracervical block as you need, but again, not a routine thing. Just like Mesoprostol, do not use that routinely either. And then if you're still unsuccessful, so say you've tried like all of these things, so using an ultrasound to help guide placement, because maybe there is still, even with your traction tenaculum, the angle between the cervix and the uterus might still just be like really quite an acute angle. Get an ultrasound that helps you navigate that os, or refer to somebody who has an ultrasound for ultrasound guided placement. Okay, so, oh, sorry, it says insertion on the title and it should say removal. So we'll have some time for questions at the end too. I just want to make sure we get through all these slides. So Jessie's 36. She's a G2, P2 here for a Liletta removal. Had the IUD placed 4 years earlier, wants to switch methods, but can't feel her strings. On your exam, the uterus is anteverted, normal sized, and you put in a speculum and there are indeed no strings visible. Next slide. So what are we going to do? So first, if they had a hormonal IUD, I always assess for bleeding history. So, you know, have your periods been a lot lighter? Have they stopped? Have they come back? Are they heavy? Because that can tell you a little bit, like, is the IUD still in there or not, or if it's been expulsed. Get a pregnancy test, of course. And you can actually attempt removal without getting imaging first. The most likely thing, especially if somebody has a hormonal IUD and they're like, yeah, I have no bleeding, and your pregnancy test is negative, most likely thing is that the IUD is where it should be, and you can go ahead and attempt that removal without getting imaging first. So lots of different tools here that you can use to help either locate the strings or just remove the IUD. So the Cyto brush that we use for pap smears, you can put that in through the cervical os, kind of come, give it a good twirl on the way out and see if it catches the strings, if the strings are just kind of inside the cervix. There is the IUD hook as well that some people really like. And then alligator forceps or Bozeman forceps. The Bosemans are on the very bottom here, the alligators in the middle. I tend to use the alligator forceps in my practice. And with that, I do use a paracervical block like we were just talking about. Sometimes you need dilation, but that is very uncommon because the alligator is very small. And then plus or minus ultrasound guidance. So in my clinic, I have an ultrasound handy, so I do use it, but you do not need to have one handy, and I'll talk about a couple tips if you don't. So if you're unsuccessful, say you've tried all these things, you even, you're like, I just don't feel anything in there, that's a time to just confirm your IUD location. So getting an ultrasound done or a KUB x-ray. Obviously the ultrasound is going to be the thing that tells you for sure this is in the uterus. X-ray sometimes can be misleading because of course the uterus has a natural tilt to it. And so it might look on the x-ray like the IUD is like, you're like, there's no way this can be in the uterus because it looks like it's sitting really, it's not oriented right. But most often it will still be in the uterus. And so then, using an ultrasound to guide removal with those alligators or refer to a clinic that does have an ultrasound. And if there are no strings, so say the patient comes in and they're like, I just can't feel my strings, and you confirm that it's in the right place and they don't want removal at this time, you do not have to do anything. Say, great, come back when you are ready to have it removed or replaced, and we will deal with the no strings issue at that time. All right, so tips for success. So consider a paracervical block when you're going to be using like a forceps of some kind, or like that you're going to need to dilate again. And the paracervical block, you give it just like you would for an insertion. And really the key here is to insert the grasper just beyond the internal os. I have a lot of residents that come through my clinic, and I find that the number one thing that happens when they attempt this, even with our ultrasound on, is so if your IUD is like sitting here, their grasper is coming in, they go way past, they're like at the fundus. And that is uncomfortable. If you're bumping the fundus and the side walls of the uterus, that is definitely way more uncomfortable for patients. And really, like if you're the base of your IUD, it's really just inside that internal os. And so if you come in with your grasper, come just inside, you're going to grab right at the base. You're going to get it first try, like 9 times out of 10. And so just thinking like, how far in am I? Do I feel the like little bump of my internal os? And it's going to be right there. And then of course, you can always use an ultrasound if you have one. All right, so Ilya is a 28-year-old G0 here for Paraguard removal. It was placed 7 years prior. They want to get pregnant, and on exam, the uterus is anteverted, normal sized. On imaging, so this person had an ultrasound done before, and the ultrasound shows partial embedment of the left arm of the uterus. You have placed your speculum and you see strings, but you are worried because this ultrasound says that the IUD is partially embedded. So what is your next step? And I would love to hear opinions on this. So chat or unmute. Therese, pull on the strings. Yep, that is absolutely right. Pull on the strings. Next slide. Yeah. So just pull the strings. Ultrasound sensitivity for embedment is actually quite low, and really as few as 10% may be embedded. And the majority of these you can successfully remove in clinic by just pulling on the strings. And so for this patient, say you try pulling and it doesn't budge, and now you're like, oh boy, maybe it really is embedded in that left arm. So what are you going to do next? Next slide. So if you can pull, sometimes there's enough give that you pull the strings and you can see the base of the stem come through the cervix. Grab that part with a ring forceps because it's going to let you pull a little bit more firmly than what you can just on the strings, because your strings can snap off. You may also want to consider hysteroscopic removal or just referral at that point, and any and all of these are okay. Sometimes too, if you can, if maybe you pull down enough and you see the stem, if you have like an alligator or a Bozeman forceps, something that's thinner, you can grab the stem, push everything back up inside, because sometimes you need to like push up to dislodge the arm from the side of the uterus, up and into the uterus to dislodge that, instead of kind of just pulling down. Sometimes it's just digging it sort of deeper in. And so that's something else that you can try as well. So maybe for this patient, you saw the stem, you grabbed it, just pull harder, and an arm broke off. And I've seen this happen much more frequently with Paragard than with any of the hormonal IUDs. So now you have an arm that's broken off. So now what are you going to do? So you can attempt different methods for this removal. You can get an ultrasound or an MRI for localization. Usually an ultrasound, they'll be able to tell you no problem, because the copper on the arm is quite echogenic on ultrasound. Hysteroscopy is often the way to go. Using ultrasound guidance to try to grab a fragment of an IUD is often difficult, and hysteroscopic removal sometimes is necessary. And so, referral if you do not have the capability of doing hysteroscopy yourself, or you can also just do nothing, especially if it seems like it's deeper in the myometrium. We don't really know a lot about pregnancy with a retained IUD arm, but the risk is likely very, very low of anything kind of bad happening. And when the device is more, that arm is really in the myometrium, we don't think that there's a lot of risk of it being a contraceptive still. And so, especially if it's really like embedded in there and you would have to like cut into the uterus or really go digging to go take it out, the risk of doing that to future pregnancy is probably higher than just leaving it in place. All right, final one. So Kayla is 34 years old. She's a G2P2 with a missed period. Had a Kylena placed 2 years ago, and they're worried that they might be pregnant. So there is a positive pregnancy test in your clinic. Uterus is 7-week size. You do see strings. You get imaging. There's a 6-week intrauterine pregnancy, and the IUD is in the lower uterine segment. So what do we do next? And I'm going to kind of keep going to give plenty of time for cases. So next slide. So it's important if somebody has an IUD in place and are pregnant that you get imaging very early to rule out an ectopic. Ectopic rates with an IUD in place, I've listed here with the copper IUD, about 15% of pregnancies with an IUD are an ectopic, and with the leave-in adjusterable IUD, about 27%. And of course, you have to keep this in perspective, right? Because overall pregnancy rates, right, are like under 1%. Per year with both of these devices. And so, the ectopic rate in reality for these is very, 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 very low. But of course, if you get pregnant with the IUD in place, the ectopic risk is higher than sort of baseline people not using birth control. And so get your early imaging to make sure it's not an ectopic. And then there's a really high risk of pregnancy loss if you leave the IUD in place, 40 to 75%. It's pretty varied in the literature out there. But after you remove the IUD, their risk of pregnancy loss returns to just baseline population risk. So it's important to try to remove the IUD, especially if this is a desired pregnancy. If it's not a desired pregnancy, you should still remove the IUD, and then of course help the person get to a provider who can help them with their abortion needs if that is what they desire. And so if the strings are there, just pull them, remove it. If they're not, present, you can use, again, ultrasound guidance is more important here with an alligator forceps. Some people do this hysteroscopically. There's one provider at the U that's how they do it. I've had success just with the ultrasound guidance and the alligator forceps to remove this with the pregnancy in place. Of course, you have to counsel the patient that when you pull, even if you have strings visible, that when you pull the IUD, there's a potential that you're disrupting the gestational sac. If the IUD, like this case, is in the lower uterine segment and the pregnancy is above, that is extremely unlikely. All right, so for those final take-home tips then, so always use a tenaculum, use a curved sound if you can. Again, remember when there's no strings, the device is going to be just past the internal os, so you don't need to go like fishing way up high inside the uterus. And for most removals, if there are strings, just pull them. Awesome. Great, that is the end of that. So if anybody has questions or comments, I would love to take them.
Yeah, feel free to just unmute yourself or pop in the chat, whatever works for you. We can also, if you want to still percolate and consider your question for Dr. Kaiser, you can feel free to put it in the chat anytime and we can readdress it at the end as well. One question I had for you, Dr. Kaiser, when you're grabbing the IUD with the alligator forceps, do you find that you're more commonly ultimately grabbing the strings or ultimately grabbing the device itself when you're taking them out?
So most commonly, it's still grabbing the strings. If you think about the IUD, the base of the IUD has like the little circle where the strings are attached to. And oftentimes just going in right to that base, you're actually going to hit strings first. And so some of my trainees, when they're in the clinic doing these with me, they're like, I don't feel anything in my grasper. And so then they keep like trying. I was like, no, you probably have strings. Just like grab right there, pull. And again, nine times out of 10, they have the strings and it comes right out. Sometimes the strings are like folded and they're flush along the body of the IUD. And in that case, sometimes you are actually grabbing like the tip of the base.
Great. Any other questions, or otherwise I'll start with case presentation and you can feel free to pop in questions into the chat as we go. Okay. Oh, here's.
Oh, great question, Treese. Yeah, so the question is if you get an ultrasound for missing strings with the LNG IUD and the ultrasound states that there's an embedded arm, patient has no complaints, no symptoms, you need to remove it. No, so that's a great point that I should put in my slides for future talks. If the ultrasound shows concern for like an arm is embedded, as long as the IUD is still correctly positioned and the patient's asymptomatic, so they're not having any like abnormal bleeding, they're not having like worsening cramping pain, things like that, you do not need to do anything about an ultrasound read that says that it's embedded. If the patient wants to keep the IUD, they can just go ahead and keep it. And then you would also say, you talk to them about that they see this, but that it's not always that accurate and that removal should still not be a problem when they're ready.
Great, awesome question. Okay, I'm going to get started with our case presentation here.